In most cases, pain is the most straightforward indicator that someone is suffering. However, when pain persists longer and affects selected sections of the body, it becomes a bigger problem. Peace and light to you all. My name is Dr. Sonia Fulgham, and today I shall be talking about various pain disorders, including fibromyalgia, diabetic peripheral neuropathic pain, complex regional pain syndrome, CRPS, osteoarthritis, chronic low back pain, trigeminal neuralgia, and temporomandibular joint disorder, TMJ. Fibromyalgia, also known as fibromyalgia syndrome. Fibromyalgia is a systemic disorder that affects the bones and muscles. The main characteristics of fibromyalgia are musculoskeletal pain and generalized reduction in the pain threshold. In addition, fibromyalgia may be characterized by the following symptoms: mood issues, sleep disturbances, fatigue, joint sensitivity, and widespread pain in the knees. Fibromyalgia and treatment. To illustrate how fibromyalgia may present and be treated in a clinical setting, allow me to share a clinical case about a young African American woman, age 33, who came into our office complaining of sleepiness, whole body pain, trouble recalling where she had kept stuff or important conversations, and frequent mood swings. After the evaluation, the following interventions were recommended. A sleep routine was set for her to ensure that sleeping and waking time was regulated to ensure that she gets enough quality sleep of between 6 to 8 hours every night. Since she owned a bicycle and lived near a park, it was recommended that she rides her bicycle to work and jogs at least twice a week in the park. The resident nutritionist also prepared and recommended a healthy diet. After 3 weeks of therapeutic and non-pharmacological interventions, some great improvement was noted, although the pain had not subsided completely. Together with the therapy, she received pregabalin, and after a week, she began complaining of a sense of floating and dizziness. That was when duloxetine was started and the symptoms improved, thereby informing the gradual tapering of pregabalin. Other medications that were under consideration had duloxetine not worked included gabapentin and misoprostol. Now let's talk about diabetic peripheral neuropathic pain, which damages the nerves in diabetic patients. It is important to note that it is not the only form of neuropathy, although it is the most common diabetic neuropathy. Sanjay, of course not his real name, is a 67-year-old Asian American man who was diagnosed with diabetes mellitus in 2014 and presented at the clinic with complaints about tingling that resembled electric shock coupled by occasional burning sensations. Complaint about pain and numbness within the feet and the calf distal aspects, which seemed to worsen at night and cause him difficulties with sleeping. Symptoms indicating muscle weakness manifesting especially in uncoordinated works. Results of an observation demonstrated that Sanjay had severe foot problems like ulcers and infections. Now let's talk about treatment. And upon ruling out any other potential causes for peripheral neuropathic pain, establishing treatment goals, and optimizing glycemic control, Sanjay's first line therapy include gabapentin at 100 milligrams per bedtime. With reduced nighttime pain, he could sleep better. Unfortunately, the intensity of daytime pain remains the same even with the increased dosages of gabapentin. And at that time, the L'Occitane was initiated at 30 milligrams per day. Although he could not engage in his daily physical activities like Wednesday night dance lessons, Sanjay developed mild stomach upsets and occasional nausea in the morning, all of which was manageable according to him. And for better improvement, gabapentin was replaced with pregabalin. And with significant improvement being registered for Sanjay, the second line medications that were considered include venlafaxine, and opioid-like drugs including tapentadol ER and tramadol, and topical treatments like capsaicin cream. And to help with agitation and mood changes, the selective serotonin reuptake inhibitors like citalopram, paroxetine, or escitalopram may be considered. Complex regional pain syndrome, or CRPS, refers to a group of conditions that were described previously as Sudeck's atrophy, algodystrophy, Calzaglia reflex, sympathic dystrophy, and various other diagnoses. A white 38-year-old American female nurse was admitted to the outpatient clinic after complaining of spontaneous or unprovoked pain that was fluctuating at times with activity. According to her, it felt like prickling pins and needles or a burning sensation at times. She also complained that her right hand was in prolonged or excessive pain after using it with ordinary physical contacts, such as shaking hands, feeling extremely painful to her. She also complained of the right hand feeling warmer than the left hand. Upon observation, it was found that her right hand was a bit swollen. It was observed that the skin on the right hand had become scaly and thick. Her right index finger also presented with limitations of range of motion, possibly due to the reduction of flexibility. So let's talk about the treatment for CRPS. The primary therapies that were used on her include physical therapy and rehabilitation of her right hand by keeping it moving to lessen circulatory symptoms and improve blood flow while maintaining function, strength, and flexibility. After some time, it was discovered that the CRPS was affecting her psychosocial well-being and increasing situational anxiety, especially whenever she had to use her right hand. This necessitated the introduction of psychotherapeutic interventions. Although the U.S. Food and Drug Administration has yet to approve any medications for the treatment of CRPS, pharmacotherapy was deemed necessary and it comprises of pregabalin, tramadol, gabapentin, N-acetylene, and oxycontin, an opiate to treat the swelling. Osteoarthritis, a degenerative joint disease that affects the cartilage and numerous tissues surrounding it, is possibly the most commonly reported disorder of the joints in older adults. It may affect the hands, shoulders, knees, foot, spine, hips, and joints with different signs and symptoms. For example, Ms. Dove is a housewife, age 56 years old, and a mother of four. She presented at the clinic with the following symptoms, which was aggravated by long walks and long staircases to her 13th floor apartment. Pain of the range of motion in the left knee was part of a symptom. Limited range of motion and stiffness, especially in the morning, that lasts about 45 minutes to an hour. Swelling. She was also found to be suffering from lateral instability. To perform the diagnosis, besides listings of the symptoms and the observation of Miss Dubb, the following were performed: a neurological test, an x-ray which revealed osteophylactic changes and narrowing joint spaces, particularly in the medial side. Since osteoarthritis of the knee was already confirmed at this stage, there was no need for an ultrasound, a CT scan, or a scintigraph. So, before designing and offering treatment for Ms. Dubb, it is important to confirm whether she is suffering from mild, moderate, or severe osteoarthritis, since each requires different forms of treatment interventions. Non pharmacologic that was performed throughout the entire treatment period included regular range of motion exercises, regular muscle strengthening exercises, including cycling and swimming, and pharmacologic interventions became necessary. And she was started on acetaminophen, which is considered affordable, safe, and effective. After a while, with minimal improvement, a non-steroidal anti-inflammatory drug, naproxen, which is sold over the counter, was introduced and 2 weeks later was replaced with ibuprofen because they complained of gastrointestinal problems like bloating and constipation. 4 months into treatment, quadriton and glucosamine were added. Persistent pain led to introduction of opiate treatment, which is monitored for dependence and potential abuse. With significant improvement of her walking, corticosteroid injections was considered. The knee osteoarthritis continues, and hyaluronic acid injections became necessary. After failing to achieve desired results in 12 months of various treatment interventions with Ms. Dubb, the physician became and started to discuss with her about total joint replacement. Typically, back pain is a result of stresses on the ligaments and muscles that affect the spine. Most acute cases can resolve in about 3 to 4 weeks. Unfortunately, some cases develop into chronic low back pain or CLBP. Thus, it is critical that any CLBP assessment considers focused physical examination and patient history to evaluate for symptom duration, and CLBP is typically pain in the lower back that lasts for a period exceeding of 12 weeks. Exist of risk factors for possible serious conditions such as cancer, cardiovascular disease, and so on. Spinal stenosis and the radiculopathy symptoms, existence and severity levels of neurological defects, the potential psychosocial risk factors, and let's talk about some of the symptoms. Johnny is a 44-year-old and works at a children's park in Chicago. While playing with one of the children, he fell and hurt his lower back in October 2018, and the pain has persisted for 16 months by the time he was presented at the clinic. Occasionally, Johnny had experienced minor tingling in the lower back, especially when carrying or lifting children at the park, although this oft died and went away without the need for medical attention. He also occasionally felt a burning, stinging pain that ran from the lower back to the left buttocks and foot, and muscle tightness and spasms in the hip, lower back, and pelvis. Now let's talk about the treatment for chronic low back pain. As is normal with most cases of low back pain, the physician recommends combining the following: non pharmacologic treatments, including an exercise program targeting improvement of abdominal muscles, strength, and core stability, education on back friendly lifting and posture techniques, training on relaxation and meditation techniques. Pharmacologic treatments for Johnny included a dose of tramadol ER at 100 milligrams per day, which was doubled after 2 weeks. The treatment was coupled with 325 milligrams of hydrocodone during the first week. Gabapentin was also introduced at 100 milligrams twice daily. Over-the-counter pain-relieving medications with controlled release were introduced at the beginning of treatment, and Johnny's function improved greatly, enabling him to resume his work at the park without a problem. He also returned to his local gym where he does body aesthetics as a hobby. One of the most peculiar diseases, trigeminal neuralgia, is also called tic douloureux, or Fothergill's disease. It gets its name from the trigeminal nerve, which is the biggest cranial nerve. The symptoms include experiencing severe jabbing or shooting pains that resemble electric shock and that could last for some seconds or minutes, non-triggered spontaneous pain attacks for a few seconds or minutes, and triggered pain attacks from activities like chewing, talking, smiling, brushing of teeth, laughing, touching, washing face, or speaking, especially in areas where the trigeminal nerve is, such as lips, gums, teeth, jaws, and cheeks. Involuntary muscle cramping or twitching. Diagnosis can be done through a neurological examination, including reflex tests or magnetic resistant imaging, MRIs. The treatment of trigeminal neuralgia often begins with medications, including anticonvulsants like carbamazepine and oxcarbazepine, Lamotrigine, and phenytoin. Antispasmodic agents to relax muscles such as baclofen can be combined with carbamazepine or used alone. The temporomandibular jaw (TMJ) disorder affects the temporomandibular joints, which is the sliding hinges connecting the jawbone to the skull. Maria, a 24-year-old athlete and student, presented at the clinic with her mouth open after being unable to close it following a yawn, despite there being any pre-existent medical issues. She admitted experiencing long-standing clicking of her right TMJ. She presented with other symptoms such as mandibular pain, difficulty in culting teeth before the incident, pain in the ear, anterior variant characterized by prominent mandibular pain anteriorly, and preocular depressions that were linked to severe tenderness. For her diagnosis, dental x-rays revealed anterior dislocation of her TMJs, and there were no need for CAT scans or MRIs. Initial treatment at the emergency room department involved close reduction diazepam and midazolam, which was unsuccessful. She was transferred to the surgical unit where her TMJs were reduced with the help of muscle relaxants. So, before ending this presentation, let me share with you some important points. In most cases, the presence of pain is an indication that a person is suffering from an underlying condition or medical issue. Pain disorder is normally one when the duration exceeds a given period that would be considered within the normal range or keeps reoccurring, either triggered or untriggered. The intensity of the pain exceeds a given predefined level. The pain comes due to an underlying, usually chronic conditions, such as diabetes or a previous injury. And in most cases, pain can be treated without using drugs or advanced treatment options like surgery, especially when it's detected in its early stages. So, I hope this presentation has added value to your practice and that you have benefited from it. While thanking you for your time, please refer to these sources which have informed this presentation. Peace and light, and have an amazing day on purpose.